Hi, everyone. Welcome to a webinar today. I'm Dr. Bobby Birdie, periodontist and prosthodontist in Vancouver, Canada. And we're going to talk about incorporating CBCT into everyday workflows. So I hope we'll have some fun today just going through the presentation, and we'll have some questions, time for questions at the end if you'd like as well. Just quickly, those of you that don't know me, that's me. I'm from Canada. I'm a Canadian, born and raised in Edmonton, Alberta, Canada. Went to dental school in the University of Saskatchewan, and then went to 3 years of pros and 3 years of perio at the University of Minnesota, and then went to still teach at UBC in Vancouver at the University of British Columbia in the grad perio department, and I teach a grad pros at the University of Minnesota. So I still have a lot of faculty stuff going on. That being said, overall, I'm in a full-time private practice. This is the view from our practice called BC Perio Dental Health and Implant Center. And then our global teaching organization is called DDI, or Digital Dentistry Institute. It's ddidental.com. So our practice is, when I first started, it was me and these gentlemen. I called it me and the old guys, where we had multiple periodontists, multiple prosthodontists, implantologists, multi-specialty practice. That's the view from every operator in our practice. We're open as a surgical prosthetic treatment center, so happy to have you come visit anytime. We have the full floor of the teaching center as well. So we went along this way for about 5 years in the practice, and then I hired this man, and we built a fully digital lab as well. So we have a full digital lab in our operation as well, with multiple 3D printers and mills and everything else. It's not a commercial lab in the sense that we don't do work for outside of our clinics. We've got multiple clinics, but it's part of our flagship at the very beginning. And then our team has grown to include multiple more clinicians and lots more expertise. We just built out the lab, and we have the whole floor now of the building, and it's been a lot of fun. So just wanted to give you guys kind of an idea of where I'm coming from and the kind of practice that we have. I'm a periodontist and a prosthodontist, so we have a very kind of niche practice where we spend a lot of time doing a lot of work. That being said, we've spent time working with DEXIS products over a decade. All of our intraoral sensors have been DEXIS. We've been involved in utilizing CBCT technology from the very beginning. It was put into our practice. Actually, our practices were built around adopting the technology. It's how much we believe in it. Multiple interviews that I give for the articles and journals out there, I always say the one tool I couldn't live without would be a CBCT scanner. Having cone beam CT in your office and really utilizing it will just really revolutionize and change the way that you practice, change the things that you can do, change how you live and how you work. And so these are the two machines we have. I've got an OP3D, an OP300, and also an iCat Flex in our various offices, with more to come. And I love these machines. The reason why we love the machines have to do with multiple reasons. Okay, one of the reasons why is the images you see on the screen, where you see the cool skeleton with some of the GUI interfaces. That's really directly off the software. You can plan things directly off the software, and that's the software that comes on the machine. So you don't have to populate into a secondary software very often, unless you want to do more and more with it. And the other reason why I love these machines is because of radiation doses. So if you look at the radiation dose of a CBCT, our CT scanners run between anywhere as low as 6 microsieverts all the way up to 18 or 17. It's still quite low in terms of how much radiation someone gets. It's far less than a medical CT, less than a digital pan most times, less than an FMX. Now that really what drives it home is that less than a full mouth series. If you imagine if you had, two, or I think when I boil down to the calculation is like 5 PAs is more than a CT. So it just depends on, each sensor, each place you're working and the type of machine you have. But CBCT technology really works. In terms of the field of view, it allows you to look at different fields of view, look at how things are, look at how much we can adopt into all the different types of modalities and what we need it for. For us, we scan pretty much 9 by 14 or larger all the time, but in our office, we are looking at things like TMJ and airway and prosthetics and surgical interventions. If I was doing endo or so, I would probably focus things on a small area, so I could really look at canals and so on and so forth. This is just an initial blueprint from our office that we built years ago. If we look at the cone beam CT scan machine we actually built it and built the office to make sure that'd be right next door to where our main surgical operatory would be, where we do a lot of complex cases and laser therapy and so on and so forth. And when those two are put together, it really allows us to just be seamless. We don't hesitate to get someone up in the middle of the procedure and go and scan them really quickly when the scan is only 5 seconds and really low radiation, and we can get a lot of information. We really use our CBCT technology to really double and triple check our work and to really make sure that we're doing a good job. So like I said, those of you that haven't adopted this technology into your office yet, I really have to say, what are you waiting for? There's so much you can do, and I'll show you what that is. So this is a general outline for our talk today. We're going to be talking about benefits of using CBCT now, like what are some of the benefits you'll get immediately. The communication benefits, to me, this is the most powerful part of cone beam CT, is being able to communicate with different clinicians, the lab, and most of all, your patients. And that really does help. Well, workflow benefits, what are some of the workflows we can do with it? And of course, some of the surgical benefits that we can utilize CBCT for. So this is a panoramic X-ray. When people are building offices and they say, I'm going to get a digital pan, they want to do it for insurance purposes most times. And in general, pans are really poor diagnostic tools, in my opinion. You can't tell if the root of a tooth is in the nerve, buccal to it, lingual to it. You can't tell if there's any interproximal caries anywhere. You can't tell if when there's so many different structures that are superimposed on one another. It really doesn't help you. And so it's one of those things where there's a lot of guesswork still involved in a two-dimensional image like a panoramic X-ray. And on top of that, I think of it as a glorified tooth counter. Like in truth, honestly, like I don't really get a lot out of the panoramic X-ray. I really don't use them much. And so the difference with that and the CBCT, there's lots of benefits that are just general of a cone beam CT scan machine and just owning one. First thing is, this is a super panel. Like you've got a super panoramic X-ray that you can use to get a panoramic X-ray, but it does so much more than that. You can diagnose more dentistry and issues. We do that on a day-to-day basis. There's things we find. Treat more orthodontic cases utilizing CBCT really, really help in a lot of aspects. We can diagnose more pathology. We find a lot more teeth that are broken or periapical radiolucencies that you didn't catch on a two-dimensional image, or maybe that area wasn't radiographed in a long, long time. And then we can execute more and plan more surgical procedures. This is definitely true. There's lots of very complex cases that we normally couldn't do that we're now able to do. And we can evaluate airway issues. We're doing more of this and evaluating airway and evaluating some of the aspects of anterior position devices and where we're going to be setting people in terms of vertical dimension of occlusion. A lot of that stuff is really coming full forward. And just simple stuff, like when you look at 3D technology, you can map out a nerve. You can tell if there's a lingual undercut in an area. You can tell, in a place like this where on a two-dimensional image, you don't know it's part of a bridge. Is this tooth okay? Why is it losing bone? On the CBCT, it tells you directly there's a horizontal root fracture and there's very little bone left in the buccal of that tooth. When you see impacted teeth, for young people, you can say, well, where is this tooth? Well, it's riding right on the buccal aspect of an incisor. Like there's a lot of things that you can utilize that a two-dimensional image just really won't show you. You won't be able to map out exactly where the nerve is on a tooth. There are many wisdom teeth extractions that we're able to complete now very easily because we can map out directly where the nerve is. And those of you that are treating pediatric patients or treating patients that are mixed dentition with such a low radiation dose, this is better than getting a pen. And a lot of times you can really get so much more information. You can see where teeth are developing. You can see if they're impacted, if they're rotated, if they're in certain areas. It really helps with orthodontics and the pediatrics as well. And that's really important. There's a lot of just instantaneous things. And from a standpoint of getting insurance approval, if you sent one of these images, especially we send them all the time to insurances, that has a whole bunch of three-dimensional stuff, we've never not gotten approval because of that. And the beauty of things like airway allows you to really just utilize things. But from orthodontics, you can really look at this and look at your lateral cephalometric analysis. You can do subtraction radiography, which we do to make sure there's some jaw growth that's completed. We can look at TMJ. We can look at how jaw closure and just in general what the health of the joint is at times as well. So there's lots of different ways to utilize this. Periapical radiolucency, you don't know which tooth is it associated with. It really helps to show you that where it actually is beginning to end. From a standpoint of having a buccal root fracture or a horizontal root fracture, you can actually indicate and see it on a CBCT a lot of times. And when you're doing endodontics and you say, why does this tooth still have problems? Well, you can visualize where you missed a canal. You can visualize where there is an extra canal. And there's lots of this information that is really valuable that will help you on a day-to-day basis in your practice. And when you have a tooth that's having problems, the three-dimensional rendering, which I utilize every day, really helps to show you. It shows you that, hey, listen, this is a blown out tooth. It looks like it has external resorption, and it needs to come out. And if you don't reflect a wide flap or go about things properly, you're going to have a really bad day or a really big defect. This is an area that's lost a tremendous amount of bone, and we have the proximity of the nose or the nasal cavity in the area as well. So things like that really help you plan. In a simple case like this, where we have a patient that had wisdom tooth extraction done elsewhere and is continuing to have infections and problems, and then you take a CBCT and you can actually see, hey, listen, there's actually a hole in the mandible where there was debris and stuff that need to be debrided. And we actually went in, cleaned it out, filled it up with just PRF, and the rest is history, healed up perfectly. So just being able to visualize why something's happening or visualize things on a three-dimensional image just provides you with so much more information. And you're never going to get these views in any other type of radiology that you're going to use in dentistry, which is pretty cool. Cases like this, as a periodontist, I say, well, is that tooth root cracked, or how bad is the defect in that area? Well, look at that on a three-dimensional rendering. You say, gosh, there's no bone left buccal or lingual around that distal root, and the furcation is completely exposed. This tooth needs to be removed. We probably have to graft. If we're going to do an implant, it's going to be through the mesial root, and we're just going to have to graft like crazy. So it helps us plan, helps the patient that sees this image look at it and say, gosh, that's my tooth. I've lost that much bone. Wow, I need to do something about that. And that really does help. And so on and so forth, seeing blown out buccal plates, seeing loss of bone in areas, periapical radiolucencies, and seeing what you have to do and how bad something is, and being able to communicate this to your patients is pretty awesome. And just planning out simple implant surgery, understanding where implants need to go, where the anatomy is and where things are, and deciding what's going on. And cases like this is the case I like showing. It's the case that we did over the last few years, which is pretty excessive. Someone walks in like this and you look at the pan and say, okay, they've lost some bone, but it looks like there's a lot of bone to the nose, and we've got a lot, someone's tried to graft in the area. But then when you actually visualize it in 3 dimensions and you look at how large the defect is, how much half the maxilla is pretty much missing anteriorly, the whole premaxilla is broken off or gone. And then when you look at it and you look at it in the 3D rendering, you can really see and visualize what you're dealing with. You can see the titanium reinforced PTFE membrane, and someone's put tacks in the area as well. And that helps to visualize. You can also show this to patients, say, listen, this is a really big defect. And so when you do something about it and graft the heck out of it like we did, and understand that, we've got to get things going, well, this allows us to see what we started with and what we did and where we've ended up, and how much graft is in the area, how things have stayed closed, how well things have healed. And then we follow this through healing and follow this as we get through it. So using CBCT technology is something that we use every single day. And by adopting this technology in your office, it's something that you will definitely Never regret. You will definitely enjoy it. You will, and if you can utilize it for the things that are available, well, you can check VDO. There's so many things you can do with CBCT instantaneously. It'll help you provide more dentistry to more patients, help you diagnose more dentistry to more patients. And just in the end, it'll make you money. Like in the end, it's going to make you money. The reason being, as I say that, is we haven't charged for a CBCT scan in over a decade. And when I look back, it's made us millions of dollars just by diagnosing more and more and more dentistry over the years. Communication benefits is the next thing on the outline. Let's take a look at that. This to me is the greatest benefit of CBCT technology. This is a video that was taken like 10 years ago. And you can see that we're using an iCat, we're taking iOS scans, and we're trying to just amalgamate or digitize our patients. Those of you that have any kind of intraoral scanner in your office, I truly hope you show those scans to your patients. You show them their teeth, you show them what's going on, you show them because they think that's really cool and they can really understand and see what's going on. CBCT technology is no different. We can do the same thing. We can take 3D technology and we can then sit down and treatment plan a case, whether it's for implants, whether it's for bone regeneration, whether it's for extractions, whatever else it is. And we can show the patient and say, listen, this is what needs to be done. You see how thin the bone is? Or we can show them in this case and say, listen, these are the 3 areas where we think you need implants. You can see how the bone dips on the buccal aspect and the cross section over here. And that area needs a graft. And the beauty of this is that this is one scan. It's one software for us to plan the case. We can show it to the patient, the consultation, and plan it with them so they can see what it's like. The communication speaks for itself. And then after that, what ends up happening is we can add bone if we need to in the future, but the patient knows that, and it's not a before and after photo or someone else's mouth. It's their mouth. It's instantaneous. It's one software. And the beauty of this is it helps you practice. Now, when I'm doing something, I already know what size of implant I'm placing, where I'm placing it, how many I'm placing, and if I've got a graft or not. It allows us to provide an estimate to the patient that's very accurate at the very beginning and really allows us to be a flat fee office. And so little by little, every single case, the more and more we do this, the more and more we plan, we see something going up into the sinus, we tell the patient, you see this black area, this is your sinus, there's no bone in that area. And we've got to put an implant in, which is like a titanium oxide screw that goes in the bone. And when it goes in the bone, we need the bone to be there. And so if it's not there to begin with, we've got to grow it. We've got to build it. And people will understand that it's their mouth. It's not somebody else's. And so understanding this information is one thing. Most people don't get dental jargon or dental language in high school. As a result, when they don't get that stuff, when you talk to them about mesial or distal or functional or asymptomatic or whatever else is the fancy words we use to explain things as dentists, they look at you with a deer in the headlights. They have no clue. They gloss over and say, okay, doctor, tell me how much it's going to cost and I hope it works out well and maybe I can afford it. When you actually show them the scans and you show them the information and it's their mouth, every single week we have someone take a photo of it and post it on Instagram or post it on their social media or show their friends and say, check it out, dude, this is my mouth. I've got like 2 nerve openings. So cool. This is my dentist's office. I didn't know this was possible. And it's a 5-second scan, something that we can utilize and show them on a day-to-day basis. And I will tell you that we've been doing this with cone beam CT scans on our patients, every patient, and showing them their own scans for over a decade. And we've adopted iOS scanning and digital impressioning since then and done that as well. And I'll tell you, still to this day, showing patients their own CBCTs with the bone and the tissues and everything you're going to do is still more impactful than a digital impression. It's much more impactful. And a lot of the times the reason why is because you're discussing something that's much more either invasive or comprehensive or specialized. And that's really important. So when we take CBCT technology and we take an iOS scan like this and we try to amalgamate them, we can put them in the workflow. And so in this whole patient communication system or this patient communication attributes of everything, we try to take this and put it into workflow. In the next section, I'll talk more about this in detail. But in general, we want to be able to plan a case, whether it's implants or not, communicate things with our patients. The pink line in this cross section would be the soft tissue, which you would get by amalgamating the CBCT and the digital impression. Now, does it have to be digital? No. You can just have CBCT. That's the only mandatory step. After that, everything else could be analog. You could take a normal alginate impression and still digitize it to make it part of the digital workflow. We can go as far as planning the implant, planning the abutment, planning the crown, planning the design of everything, and then decide what we want to do. And in the end, we can even take it one step further in our communication. We can take all this technology and amalgamate it, and then plan things that includes facial scanning and then face and someone's face. So see a case like this where there's the same iOS scan I just showed you. Patient walked in, and we take our images. The reason why these images are specifically sized this way is because they're taken with a phone. Same reason why, and then we take an iOS scan, a regular impression. Doesn't have to be a digital impression, it could be a regular impression. We can see that there's an area where an implant has been placed, and we're looking to say, okay, well, where are our smile design going to be? We can take our smile, and you can see it's blurry because it's taken from a snapshot of a video, just to get the perfect image to line things up. We communicate to our patients using digital technology in just what are the size of the teeth? What are the size of the crowns? How are things going to look? And at that point, using a bird's eye view, we line it up and spend the time to say, hey, listen, this is what we think based on your bone, your tissues, everything, your smile design. This is what we think a two-dimensional rendering of what we think the teeth should look like would be. What do you think? And if they don't like it, then we're able to take each tooth out, shape it, adjust it, put it back, whatever we got to do just to be able to put it back. So in the end, you're using technology to really, really communicate. CBC technology is part of this workflow. The patient communication is, in my opinion, the best part of using digital technology, whether it's iOS scanning or cone beam CT or facial scanning. And this software is now easy. There's lots of quick ways to do it. But we put this together, and you can say, well, this is what we started with. We had this healing cap area. We thought this was going to be a big deficiency. We've got a lot of areas, and we just deliver what we said we could. Now, we didn't do the whole mouth. We only did up to the first premolar on each side. We didn't do any grafting. We didn't do anything. We kept the implant where it was. And so you can imagine, by communicating to the patient what we're doing and say, well, we're communicating, hey, listen, this is your mouth, this is your smile, this is what you're doing. Can we provide you with something that's also going to be pretty reactive and pretty happy? And so in digital smile design or digital workflow or communication, being able to use cone beam CT scan technology to communicate to your patients, to understand, so they're part of the journey. You want them to be part of the journey, because if they're part of the journey, they're going to be compliant. They're going to understand how difficult something may or may not be, but they also will be able to say, hey, listen, I get it. I lost bone there. How do I get that? Can I grow bone back? Or gosh, I can see my tooth needs to come out. There's an infection there. Or wow, yeah, I need a root canal. Or shoot, I think I'm having trouble with my teeth. I'd like to straighten them up. Where are all the roots on the teeth? And so that really helps. Some of the workflow benefits that we talk about is that when we talk about the digital workflow and we look at all these things, right? The only mandatory step in the digital workflow for surgical prosthetic treatment is a cone beam CT. You need this. It's the mandatory step. That's why it's triple starred. Everything else about this is optional in the sense that you need initial impressions. They can be regular impressions or they can be digital impressions. It doesn't matter, but you definitely need a CT. You need a planning software that will allow you to amalgamate those two. There's lots of softwares out there. DTX Studio is a good one, but we also have the software that comes on the actual machines. It really helps as well, which a lot of times can be DTX. And then you talk about guided surgery, which we'll talk about at the very last section of this lecture, just to see if that makes some sense for us to do on a routine basis. So we take our 3D technology, we take an iOS scan. It could be a regular impression too. We could snap some alginates, and we put them in the workflow. So let's look at this for something simple, like a single molar. We use the technology for us to look at this case, and we can take a look at a single molar and say, gosh, we've got to do some work. You can also see there's some work that needs to be done on that premolar as well. And we got there, don't worry. We look at the workflow and say this tooth is not doing well. The CBCT indicates a root fracture, which would be hard for you to diagnose on this two-dimensional image. There's a bit of a shadowing on the mesial root. The distal root also has a little bit of a shadowing at the apex, but do you know if it's cracked or not? How do you tell? I'll tell you that if you send it to an endodontist, the first thing they're probably going to do is take a CT. And so having that in your office allows you to really diagnose a lot more treatment so you can see it. And so when we treatment plan the case and we take a look at what's going on, we can really see, we can look at the image, we can spend time to make sure that we know what's going on and really just visualize things on the CBCT so we know where we're headed. And then if we have to remove this tooth, which we did in this particular case, we can now treatment plan the case through a digital workflow. We can map out where the nerve is. We can plan our implant in advance. We can decide how many implants we want, which is one. We can decide the size of it. We can plan the abutment on it already and the size and shape of the restoration. And then if we want to feel like we want to go about this at the end, we will then even 3D print a surgical guide, which is now in our office with 3D print all the time. In the digital workflow, in a case like this, the first thing we got to do is do an atraumatic extraction. We got to get that tooth out without ripping it all to heck. And that's what we did here. And then bullseye, right? And it's one of the hardest things to do as an immediate molar is to get a tooth, get an implant in the same day of a molar extraction. And so we use our surgical principles to drill. Now, how do we do that? Well, in this particular case, we use guided surgery. Guided surgery allows us to drill something, and it's based off a cone beam CT scan, and it's based off of an iOS scan, and it's based off our digital or normal impression, and then of course our surgical digital workflow. And so it's one of those things where this is how cone beam fits into all this, is that it allows us to be very, very accurate in our implant placement and our surgical interventions. So if a case like this, for instance, we're going to place an implant in that area, we're drilled our osteotomy. There's our 3D printed guide, so we know it's there. And to get the most out of cone beam technology and to get the most out of just this type of modality and this type of treatment, what we got to do is we got to make sure that we walk ourselves through the workflow, but also utilize the technology. So those of you that do any kind of guided surgery and then don't place the implant through the guide, you're actually missing out a lot on the accuracy that would be there for the surgical guide. You can see the guide is full arch because it's got to be printed specifically for the digital workflow. So in this particular case, we drill our osteotomy, replacing some bone graft material that's mixed with 30 times base human value platelets or super concentrated PRP. We use PRF, which is something that is drawn from someone's, we draw blood, we spin it down, we concentrate it, and we put this into our surgical sites as well. And we're doing all of this through this little tiny hole where we kept the tooth in, right? The tooth out, sorry. And then we use the surgical guide and we place our implant. We place our implant through the surgical guide with this tool that we utilize the cone beam CT technology to do. And then you can see here where we're exactly placed this implant exactly where we wanted it. And then from there, we can see our implant's placed at the proper depth. It's placed right where we want it to be. There's bone all around it. We're not to the buccal. We're not to the lingual. At that point, then we can decide if we want to temporize the site, put something in, put a cover screw and bury it, all those options, right? And all of it is based on exact, perfect implant placement. But in the workflow, we can provide more things. We can have the software then provide us with the ability to mill or print a temp shell, which is a temporary crown that was prefabricated that has a hole in it to pick up an abutment and also hang on to the adjacent teeth. It allows us to really get that in and stabilize what we need to do and how we go about it. And that temp shell then, like I said, the wings on these temp shells are pretty cool because they can help you line up the teeth where you want it to be, so you can really lock things in and get a great result. And you want to really spend the time, the best time you can, or the most time you can, really getting this right. And then this is an on-one abutment. This is a platform that I believe a lot in, where we place this into the implant, torque it down, and it never comes out. It seals off the implant abutment connection on the day of surgery and really allows everything to be stabilized. And so we put that in. You can imagine we planned this on the software. So we planned this in our cone beam CT derived or driven workflow. And so we not only do we plan our implant placement, we also plan to have this abutment in. So we had to plan the proper depth of implant placement, and we had to make sure there's enough room for the restorative materials, right, for something like this. And so we torque that in, and then we've got our temporary abutment. We've got an abutment that allows us to put something in and then torque it down, and then allow us to really spend the time and get to it. So, you know, the In this particular case, we are able to place an implant right down the middle, right where it should be. We're able to put an on-one abutment on it right away and really spend the time to get things right, get a temporary on it, and can look like that from the occlusal as a screw retained temp on the day of surgery, and look like that from the buccal. You can see that we did a tunnel graft, we added a whole bunch of graft material and everything else to really get it right. And then if you do this all right, you can think about it. They got one sling suture. That's the only suture we put in. Everything else was done through the hole. Everything was done immediately. They got a tooth in one day. And we can verify it. So what we always do is verify these. We look at this in our cone beam CT scan machine, and we look at it and say, is our implant where it should be? Are we too close to a nerve? Are we too buccal? Are we too lingual? And if we don't like it, we have no problem going in and changing it. So we always take a post-operative CT to make sure that we got what we wanted and that we got the result we wanted. The reason why I always encourage people to take post-operative cone beam CT scans is because if a patient ever has an issue, it's the same reason why I say when you see a restoration, a crown on a tooth, or do a filling or anything on an implant, you take an x-ray. And the reason being is you can imagine, and all of you, I'm sure, have experienced this. Someone comes into your office, they're having a problem with a tooth. You've never seen the patient. They recently got a filling or a crown or something. The first thing you're going to do is take an x-ray. And the reason why you take an x-ray is so you can see what's going on. Well, if you don't have a baseline from what it was like before, how do you know something's changed, right? And so then what we end up doing is looking at something and saying, oh gosh, there's a overhang, that must be the problem. Or gosh, this who would do it that way? And then we start throwing each other under the buses. But in general, what we need to do is document things properly so we can see what's changed. That's very important in important use of radiology, but also super important when it comes to surgical intervention and making sure that we double and triple check our work when we're doing surgery. And so, in the same thing like this, we can take our 3D rendering and take a look and say, wow, that buccal graft looks pretty big, pretty thick. We got our implant right in the middle of the bone. We're happy. And we can take a look at that as well in the bone rendering as well, and really take a look and say, okay, our implant's right as it should be. I don't see threads through the bone. I can see that we added bone on the buccal aspect where we needed it, which is towards the crest. Our implant's in the middle of the space, and we're happy. And so that allows us to take a look at a lot of things, allows us to visualize where the mental foramen is, where everything else is as well, and really allows us to do a really good job. And so when we do all that and we spend all that time, the case can look like that at 2 weeks post-op. And then at 2 months post-op, it looks pretty darn good. We've got a good gingival zenith. We've got a good band of keratinized tissue where patient's super duper healthy. They've had a tooth since the beginning. You can see we started to work on the top here as well to try to help things out. And that allows us then to take a final impression. Now, when you take a final impression of a case like this, and you can imagine the surgery was done guided in the sense that it was driven by cone beam CT. The placement was guided through the 3D printed scan guide. We placed an abutment onto the implant, which is an on-one platform, which allows us to seal out the implant abutment connection the day of surgery and just work from this platform, kind of like a tissue level implant, but has the benefits of us removing this if we ever want to and go further to the implant head, which is really amazing. You can see by doing things atraumatically, but still respecting things, we give a really thick band of tissue to cause stability around the restoration and really provide us with what we want. And all that just is proof in the pudding. You know what I mean? And it really allows us to get what we want done. And then we look at the final crown. And if you look at the contours of this final crown, we always show these photos and they look like, wow, what great photography. This looks so cool, looks so nice. We take a photo on a mirror and it looks so cool. But in general, it's not the wowness of the photo that matters. It's the contours of the restoration that matters. We don't have a big bulbous crown. If you look, the crown is all of it's creeping down towards the platform. It's under contoured on the buccal. It's reaching for the proximal context in a gradual manner to have a good emergence profile. We don't have a mushroom top crown, which is hard to clean, hard to maintain. And all of this is driven by the cone beam CT scan that we took to help us plan the case properly. Because then when the crown goes in and it's in there, we've got a really thick band of tissue, really great stability of the restoration and everything else. And on the radiograph, that's pretty perfect when it comes to implant dentistry. We have the right size of implant for the right size of tooth at a proper depth with an emergence profile that's pretty even on both ends. It looks like a mushroom, looks like a flower, looks like something that's in nature. Nature always has symmetry, right? We have the stalk of a tree or the trunk of a tree, and then we have the branches of a tree. Well, an implant should be no different. Our teeth are that way, right? We have the middle of the tooth, and then we have the crown. Well, it should be no different for a dental implant. So cone beam CT scanning and utilizing that in your office every day will really allow you to provide this type of therapy on a routine basis. And that's pretty awesome because that's what we want, right? We want to provide repeatability, predictability, but also provide care that's going to be really, really stable. All right. So the last section of the lecture is going to be surgical innovations, or what are the benefits of it, right? Well, you saw some of that already, and I'm going to show you some more that are really, really cool just because, it's fun to show some fun stuff. So if you look at this, this patient has been to multiple places saying, well, we can't help you. It's not possible. You just need to eat food. The dentist. This patient's been a dentist for 60 years. You can see how thin the mandible is. You can also see that the image is really, really cool, but it shows you what the facial moulage is like and what the facial profile is like. And these are all just from the same, 5-second scan or 6-second scan, super low radiation. This is not a high radiation scan. This is the only scans we take. We don't take high radiation scans. We take the lowest scan always. And that's what all the images you've seen are those scans. Same thing. This image shows you the facial, all from the same scan. You can see the soft tissue, you can see the facial profile, you can see the lips and how things are draping. This allows a lot of the ability for what you can see prosthetically. And then you can see how thin the mandible is. This is really, really difficult. You also can't even see the maxilla. You're seeing right through it. You're right into the spine. And so this is a very, very atraumatic case. Very, very atrophic case. And she had been to multiple places, and we were able to place 4 lower implants and 5 upper implants for the patient and give her teeth in one day, which sounds very crazy, very, very extreme. And absolutely, we gave her multiple options. We gave her the option of a submandibular implant, which would have been across the lower jaw. We gave her the option of hip grafts and non-oral grafts to help build up the mandibular bone. We also talked to her about jaw fracture and the risk of it. And so we spent a lot of time, risks versus benefits, a lot of times really making sure she knew what was going on. And in the end, we got some good looking temporaries in there. Those are just dentures that are converted into provisional restorations. You can see how big and how tall the mandibular restoration is compared to the maxilla. It also helps to drive home the point that you're in incisal edge position, where your vertical dimension of occlusion really doesn't change much in your lifetime, and where your teeth need to be or where your teeth need to be. But the bone levels and the tissue levels can diminish greatly over time. And so, a case like this, when we take our final impressions at 8 months of loading, the patient was loaded upper and lower for 8 months to make sure everything was stable and utilized and fine. And then we take impressions and we make these final prostheses. Now, these prostheses, I like showing this photo all the time. These are hybrids or bridges. And the reason why I like showing these is because you can tell how the underside of them are just flat, convex, or flat and smooth. And that allows it to be convex or smooth. It allows you to then make sure that the restorations are stable, and also make sure the tissues are stable and make sure things are healthy. And it's really important to understand that. Okay. And you can, by designing the surgery, planning the surgery from the very first CBCT, understanding bone levels, understanding tissue levels, it really does help you make sure that you provide a restoration or provide therapy that's going to be predictable and healthy. So there they go in. You can tell this case is really old because all of the acrylic is classic acrylic with classic denture teeth. We stopped doing that about 4 years ago, and everything from there has been milled by a milling machine, much stronger, much more hypoallergenic, and much more stable. But good looking restoration. She's super duper happy. And now it's been 8 years. I think the most recent photos I have on the presentation, I think, is 6. But super stable, super extreme. I could not in a million years have done this with as much minimally invasiveness, but also with as much predictability and stability without having a cone beam CT scan machine to be able to utilize. And you can see before and after what this looks like, and what we were able to provide for the patient. You can see the difference in her lip profile or chin profile, and you can tell a lot from these images. They really help. They really make sure that you drive a lot of these points home. And this patient, she's been with our clinic now for over 8 years, and she sent her sister who was also in similar had similar problems, and we were able to treat her as well. And that was just more recently. So it's things like this. Like I said before, I'm showing you some extreme cases, but I'm showing you what is absolutely possible with a cone beam CT scan machine, and also absolutely possible with what is available in terms of just being able to provide this type of therapy for people, and also provide this type of therapy for on a day-to-day basis. Pretty cool. And the images, like I said, these are the ones that come directly from from the machine and directly from the scan that you take. And it isn't somebody else's mouth; it's her mouth. So she knows what's going on in her mouth, and she can see that she sits down every year. Every year we take a CT and take images of her implants to maintain them, and we sit down and we look at them together, and we spend the time to make sure that things are the way they should be, and things are continuing to be stable. So when it comes to using CBCT in guided surgery, there's lots of different ways to do this. This is a stackable surgical guide, where you see a lot of these now with like the N sequences, the FTXs, the 360 imaging, the chromes out there. And this type of stackable guides are meant just for this Flores type of therapy that I just showed you. And it's all based of CBCT. You have a CBCT, you have impressions, and then basically you sit down with the lab technician or one of these companies and plan out what the surgery is supposed to be like, and plan out the teeth, the final position, all of it. And then it really allows you to provide therapy that's going to be very, very stable, and really allows you to do something maybe that you don't really have all of the tools and tricks to do in your office on a routine basis. And so I have a lot of people that utilize these types of things. The other thing too is that, like I showed you previously, is that with cone beam CT scan technology, you're allowed to then do static guided surgery, which is when you have a template that I showed you previously, and that template allows you to then use the drills of the implant surgery like a drill press. There's no ambiguity, there's no movement, and you know exactly where you're drilling, and that's based off of a cone beam CT scan, and also, of course, an impression. The other way to do this is through real-time guided surgery, what we call dynamic guided surgery. Now, dynamic guided surgery is pretty awesome. I tell people it's like having a GPS for your handpiece. You know at all times where you are in 3 dimensions in someone's mouth in terms of when you're drilling an osteotomy or when you're about to place an implant. And you plan this. The beauty of this is, unlike static guided surgery, there isn't another lab step that's needed. You can just scan them and go and do the work and utilize it. Now, the limitations of both static and guided surgeries, you're not going to be able to use these cases for this type of technology for every case. There's limitations. Sometimes patients can't open wide enough to accommodate the tools. Sometimes patients don't have the ability in terms of being able to look at things either. And that can be very, very difficult. So everything just depends on what's going on. And so every single area works a bit differently. And so as a result, with dynamic guided surgery, it's quite different. When it comes to other types of surgery, it just depends on what's happening. And so when it comes to dynamic guided surgery, the beauty of it is that it's instantaneous. So if you look at a case like this, we have a surgery that's being done live, where we're able to really utilize where the drilling is going to be, and where we're drilling to be able to create an osteotomy. And you can see with the screen in real time. This is the surgery is done by Dr. Chris Long, who's one of my business partners, who's the #1 user of XNav in Canada. And at all times he's looking at the screen, and you're looking and playing what I would call target practice while you're drilling on someone. You have these fiducial markers help the camera locate where the CBCT and where the drills are at all times. And that really allows you to do a really good job and really plan where things are, and really to get a great result. So these type of technologies is one of the massive added benefits of having a CBCT is now you can do guided surgery, but also you can get a real-time guided surgery unit and utilize real-time guided surgery in your cases as well, which is really, really fun and really informative and just really allows you to be that much more predictable and accurate in your surgeries. And so in a case like this, for instance, you just mark where you are. You're going to place an implant in a specific site. You're able to place an implant. It is freehand, but because you're using target practice or you're looking at the screen while you're doing it, you really are able to really get a very good result. But you're also able to pinpoint exactly where you should be and what you need to have happen. So that's pretty cool. And there's that implant placed exactly where they want it to be, where Dr. Long wanted it to be, based on the plan that was done based off of a cone beam CT scan. The beauty of real-time guided surgery is you don't need an impression. You just need a cone beam CT scan machine, and then you need the software and of course the unit to do the work, which is pretty instantaneous and allows you to do stuff. So when it comes to XNAV technologies, the beauty of this type of technology is that, like I said before, you're able to just, take something, mark where you're going to have the handpiece, and then go. And then so from there, you're able to at all times know where you are. And as you're checking things, you normally check things on the mouth so that the mouth can know. But you can see there's a marker on the mouth, a fiducial marker. Some of them have other types of ways of marking, but in general, at all times, the camera is looking. If you look at the pink and the green that's on the bottom of the screen, the camera is always pinpointing where the handpiece is, and then of course where that marker is, and the relationship of those two together allows it to always calculate where you are at all times. And so when you're drilling, you're able to utilize this technology and really see where you are in 3 dimensions at all times. It increases the predictability, increases the amount of safety that you will provide in terms of this type of surgery, and really allow you to get a great result on a routine basis, time in and time out. So another case that I used real-time guided surgery for that's been around for a while, which is pretty fun, is this one. We have a failing bridge in quadrant 3. We can see here we don't need a cone beam CT scan to tell us that this tooth is bombed out. But in general, cone beam CT scans aren't really good at diagnosing caries. They're really good at bone and tissue and dimensions and positions and all that. But diagnosing like how much periodontal bone loss is in an area or caries on a tooth is just not something. Our proximal contact is not going to be indicative. You can't get that on a pan either. That's what you need periapical radiographs for and bite wings for. But you can see here, there's a bridge here that connects two teeth, and then of course the tooth at the very back. We can see for sure that the premolar tooth that's got the root canal is not doing well and probably has to be removed. We're hoping to save the molar in the back, which seems to have still a strong amount of bone support and is pretty asymptomatic for the patient. So we take a cone beam CT scan so we can take a look and see. You can see the pan is kind of blurry, but I don't need a pan. What I need is to be able to look at things and plan things in 3 dimensions. So the scatter sometimes cannot be fun. That being said, there's settings to make this better as well. You can take an iOS scan in this particular case if you wanted to, and you could do it with a static guided surgery where you would actually have the ability to have a template and then do it. Or like I did in this case, I can go right into it and use real-time guided surgery and place these 2 implants using like the XNAV system, and then drill my osteotomies, check them on the screen at all times, know where I am in 3 dimensions at all times. And then at that point, then be able to place implants. Now, not only can I place implants, I can plan to immediately load them if I want. I could make a temporary bridge. In this particular case, that's what we did. Graft where we've got a graft, smooth off the proximals of where we adjusted and trimmed the bridge. And there's our 2 implants placed, and there's our temporary bridge that connects the area together while things are healing. And this allows us, because we're placing implants in very exact locations, we're also knowing exactly where we're placing implants from the beginning. And so we get really good results in terms of depth of placement, where we want things to be. And so then when we go to take our final impressions, we can take digital or non-digital impressions. And in this whole workflow, then we can utilize iOS scanning. Sometimes it'll help us take a shade, which is pretty cool. Like I said, more and more things that are available in digital technology and utilizing cone beam CT scan technology, and that is pretty amazing. And so in this case, like I said, we're looking at exactly where our implants are. This is a monolithic zirconia bridge, one of the first ones we did back in the day. without any porcelain on it, to allow it to see how good our color match was going to be based off of the iOS scan. And so there it is. Once again, the fancy photos that you see, don't be fooled by the fanciness. Look at the contours of the restoration. Look at the emergence profile of the restorations. Look at the access holes of where the crowns are, the access hole for the implants are coming out, and deciding where all that's going to be together. And then you put it in. And this is one darn good monolithic restoration on monolithic bridge, which was done with one surgery, they had teeth in one day. But on top of that, our color match is pretty darn good for a monolithic restoration. I'm pretty happy with that. It's not perfect by any means, but he didn't want the yellowish portion of this old porcelain that was in the area. I think it matches and blends in quite nicely. And all of this, once again, starts with taking a cone beam CT scan. Having a cone beam CT scan will allow you to get the information, to allow you to diagnose the case, allow you to measure the bone, allow you to plan the surgery, and then execute the surgery properly, and then do all the other parts of the workflow that really help you. There's more and more evidence that shows that even if you just do a CT scan and then you plan the case on a CT scan and you have it open up during the surgery, even if you don't do guided surgery of any type, your results are always better. And that is something that I have personally in our clinics, we have definitely seen over the years, is that because we are mandatory when it comes to cone beam CT technology and we utilize it for every patient, it allows us to then be very predictable in how we go about our cases, but also very predictable in what we can attain, and we can double and triple check our work. But also, like I said before, the biggest thing is it sells us cases. When it comes to being able to talk to our patients and say, hey, listen, this is your mouth, you're missing these teeth, these are the areas, these teeth are tipped, so on and so forth. It is a tool that if you haven't used in your office yet, and you don't have in your office now, you really should. And because you can really provide pretty awesome results for a patient, and it really allows you to be a clinician of your word, is what I always say, instead of a man. If you're a clinician of your word, because what you say you're going to do, you pretty much do it, because you're using a technology to really help you diagnose, gather information, and provide something that's very accurate. So when we use this technology, we use it to communicate. We use it to make sure our patients know what's going to happen in their mouth. We use a treatment plan, obviously. We also use it to gather as much information as possible so that they get an estimate at the very beginning that they don't have to worry about. They can say, okay, this is what it costs. Because a lot of times they get, well, if this happens, it's going to cost more. If this happens, it's going to cost more, all those types of things, versus this is the cost for the implants, this is the cost for the graft. And I'll tell you, us doing this for 10 years has driven the market for more and more people to do that. The reason being is because the ambiguity of the way that this is done normally is not a great idea. And as a clinician, you don't want to lose your shirt all the time saying, oh yeah, we can do it, and get in there like, gosh, I've got to use so much more stuff, or it's much more complex. But by using this technology at the very beginning, you really can provide predictable, repeatable care and really make sure that everyone knows, hey, listen, this is what we're planning, and this is how it's going to be. So that is the conclusion of my webinar today. The only thing I have is if there's any questions, I'm happy to answer them. If you have any questions, please visit our ddidental.com for education, and then you can visit our practice website at bcperio.ca. And if you have any questions, please let me know, and you can feel free to email me as well at any point in time as we go about it. So when we get into our questions here, we have a question here. Is it? Just give me a second here. So this is more of a rant, but more than anything else, basically the question is: are you able to? Does an oral surgeon or a periodontist that work with a general dentist lab coordination, is it important? And so when it comes to like an in-house system versus working with multiple offices, is it more cost? Well, I will say that when you have one office that has multiple clinicians and provides multiple different aspects of care, yes, overall the cost of treatment does go down and the speed of treatment does go down as well. But working with clinicians and working with your surgical specialist is ideal. We work with multiple offices and go about it. And if you are the specialist, it really allows you to look at a lot of things that allow you to really help and go about it too. And it just depends on each individual case and each individual treatment and how it goes on. Another question is, how do you pick a cone beam CT scan machine? Well, when I decide on a machine to pick that's a cone beam CT scan machine, the information or the advice I always give is base it not on price, but base it mostly on the software that's utilized in it. Can you use software that's going to allow you to do what we do, in the sense that communicate to our patients, make it seamless, make it easy, make it quick, and also be able to really, really provide that information to your patients and your colleagues. And then also I look at radiation dose. So how quick and how well can I use the software? How powerful is the software? What can I do with it? Can I place implants on it? Can I take measurements? Can I rotate? Can I look at different views? And then also, and how easy is it to use? And then also, how much radiation am I going to be giving to my patients? And if they're using a low dose radiation dose for that specific machine, is it going to make a big difference in the resolution of what I want to see? And so I think those things really, really matter. Of course, the size of your office and the room that you have for the CT scan also will make a big difference as well. But those things are, it all depends. Another question is, when do all these data points get incorporated to prosthetic design and fabrication? So when it comes to data points in terms of like initial treatment, when we look at airway, but we look at vertical dimension of occlusion, we look at the position of things, a lot of times that's static. And then when we look at utilizing things in terms of when things are in motion or things are dynamic, then things get utilized. When it comes to the data points in mandibular joint function, and then looking at how data points are incorporated in occlusion, that's more at the end. Things like digital articulators, utilizing motion in terms of like iOS scanning and some of the new things that are out there for us to be able to utilize it that way. So that's normally how it goes. And then the last question I had was, how soon should someone be utilizing this? Like, does it still make sense to get a digital pen that upgrades to a CBCT? And I'm pretty biased here. I don't see a lot of need or a lot of benefits of a panoramic X-ray. So if I was building a new office, or if you're thinking in the market to get something, spend the money on getting a CBCT. It's going to be much more beneficial to you. You're going to be, as long as you get the field of view that's going to allow you to see everything you want to see, which is a larger field of view. And then on top of that, being able to really utilize the technology for all the different aspects of things you really can, and really providing that to all of your patients, but also just incorporating into your office so you can do more dentistry well. All right, guys, I think that's everything. If anybody else has any questions, I'm sure you can email me. Otherwise, I will see you soon, and take care of yourselves.
Thanks for attending this Viva Learning webinar. In order to get your CE credit, you will need to pass the CE exam. To do so, return to the website, make sure you are logged in, click on either CE in Progress or My Account. Click on the webinar title and take the CE exam. Thank you, and see you next time on Viva Learning.